Thanks very much, and thank you so much everyone for joining us this afternoon, especially during your postprandial dip. I'm glad that you're experiencing it with us. So my name is George, so I work as Associate Professor in Public Health here at the university, and this afternoon I'll be presenting with my colleague Adi, who is a computer scientist and AI specialist, and also with my colleague Sam, who is an NIHR-funded PhD fellow at the university. Collectively, using our Power Ranger abilities, we are representing Neil Cockburn today, who many of you may actually get the opportunity to meet tomorrow. What we're going to be talking about today is an exciting project that has probably taken us around 10 years to develop. So if anybody criticizes it, please don't tell us at the end. So what we're going to be doing today, we're going to take you through one of the novel technologies that as a team we've been working on and show you an application of it and actually show you how over the coming days, because there'll be an opportunity for you to use it tomorrow, what the potential applications are and how it may affect you in your working roles as well. Just to start with, of course, as with all of the presentations happening, I think had Neil delivered this, it would have been more conversational, but because I love, hiding behind the screen, and as my colleagues have mentioned, who are computer scientists, they'd prefer to stand over there rather than here, we're going to do death by PowerPoint this afternoon. Got 45 slides to make through in the next 20 minutes. So, let's just go back to something here, something which we've covered a few times during the day. Many of you experience this on a day-to-day basis, the joys of electronic health records. There are loads of them. We use loads of them in this country, from a research perspective, from an analytics perspective, and actually from a service use perspective as well. Some of the ones that we're most familiar with using at the university have really been thinking about primary care and secondary care data, as well as some of the maternity care data sources. And one thing which I'm going to just highlight right from the start, I am one of these people who is an academic through and through, and I probably have not done as much service work as I probably should have done during my public health training. So right when one of the earlier comments we heard in the morning, what do academics do this for? We do it for prestige, grants, publications, all of these things which are not actually helpful to patients or helpful to anyone in practice. So over the past 10 years, we're trying as a team to move away from that model and apply some of the tools in impactful ways for patients, and that's what we're going to talk about today. So there's loads of challenges that exist with electronic health records, using this data in practice. I'm not going to bore you with them. You all use this data. You all see this from time to time. Whether this data is collected for the correct purposes and how we wish to use it in practice. Sometimes these data sets are actually expensive or tedious or difficult to access and difficult to use. We're obviously hoping as part of the Goldacre report that some of these challenges will be solved. But what we're going to cover today is just thinking about, rather than the logistical issues and the technical issues of using these data sets, there are also some methodological issues. In a way, as an academic, this is kind of good because it keeps us in business, because people come to ask us questions. But we really want to move that power from, or perceived power from the university to people to be able to sort of use at home in their own environments, in their own working environments. So I'm going to cover some of the methodological challenges that we tend to see when using healthcare records. And these come up an awful lot. So, some of you may be familiar with them. If we're running retrospective studies to look at the incidence and prevalence of certain events, we may encounter issues such as immortality time bias. We may encounter certain issues if we're going to do a pharmacoepi study, such as prescription by indication bias. And there's a ton of other different biases that we may encounter and come across. So what did we do here to overcome these challenges, and what can we actually share as sort of some best practice and some learning, and a tool that actually hopefully one day all of you can use as well? So here at the university, we've spent time developing the tool called Dexter. And what it is it's effectively a transparent automated extraction, transformation, and loading system. I'm going to hand over to Adi later to talk about the technical aspects, but from a public health point of view, it can help us with a whole variety of different study designs, and it can run data, it can produce analytics and produce outputs that we hope can actually make a difference. This is a slide that, even though I was the second co-author on this paper, I don't understand it 100% myself, but which is one of the joys of academia. Essentially, it's a tool that can ingest any form of data, and it will produce some really nice, cool things at the end with some epidemiology behind it, which Adi will talk you through. The way to think about it is it's a tool that can expedite research and analytics. The idea being that actually it should sort of reduce some of the time lags that we experience. It can standardize some of the variables that we're using, and the idea being that it should be human independent to some extent. where does this fit into the wider system in the NHS? Where does this fit into the wider patient pathway? So we perceive that actually this tool can support in all parts of the learning health system. So this is the mantra that we've started to go for. And something which we've seen, a lot of different organizations are moving in. We have got great data. Can we convert that data into knowledge? So generally, this is what most of us are quite good at doing. We're good at saying, okay, here's the data we've got, here's the challenge, here's the issue, and that's that step of converting it to knowledge. Can we put that knowledge into practice? So can we use that data to inform things such as clinical pathways, clinical decision support tools, and actually can we use what we're doing in practice to improve the data, so to complete the full loop? And the idea being that the tool we've developed here is able to support with each of these aspects. But I'm just going to focus a little bit first on the data to knowledge, because the example we're going to give you in a short while is really focusing in this area. So we worked quite hard to think about how can we automate lots of different clinical epidemiology study designs, how can we support with the emulation of clinical trials, and actually how can we even deliver data-driven clinical trials just through this platform. So here's just some nice flash papers that we've done. Not really going to help anyone in some way, but hopefully they can if we get the messages across appropriately. But what I wanted to show here is this. So this is a really large funded piece of work where we were one of the first teams at Pace to undertake an analysis of sort of the risk factors that are associated with long COVID. And we're able to do this with the use of this tool, and Adi will tell you in a moment how, but we can do a couple of other things as well. So again, during the pandemic, we were able to, at Pace, assess for drug safety, using different pharmacoepi designs. We're also able to understand and look at opportunities for drug repurposing. And then also on top of this, as I mentioned, so some of our newer trial designs that are happening across the university and across the NHS can all be delivered through sort of a data-enabled or a data-driven methodology. So this is one of the big studies happening here in the West Midlands, and it's a data-enabled trial where we're looking at what are the impact or effects of providing anticoagulants to patients aged at a younger than previously indicated population. And what we're able to do here is again, using primary care data and secondary care data applied through this analytics engine, we're able to identify what we anticipate the effect size to be to support trial planning. And then this has moved on to one of our more recently funded projects where we're actually able to not only understand what proportion of patients may end up with a certain exposure or outcome, but we're also able to deliver an intervention through the electronic health record and then continue to follow it up. So there's some of the sort of data to knowledge applications, but we're trying to move things forward in a different way. And we feel to some extent over the last 10 years, we've tried our best to get the science right. And now what we're trying to do is optimize the speed and also provide sort of further applications and opportunities for applying this technology. So something which we did during the COVID pandemic, and sort of it broadly relates to this concept of an informatics consult approach, just generally sort of in healthcare analytics. The data that we have, can it help the patient who's sitting in front of you? And can we produce those results in a timely enough manner to give that clinician an opportunity to inform the decision? So we had this question that was asked by some of our colleagues here at the hospital. People wanted to know actually for patients with diabetes, do we feel that prescribing them dexamethasone was a good option? At that point in time, there wasn't any protocol, there wasn't any guideline, but clinicians were often put in this position in front of a patient. So what we tried to do was we developed an approach to apply Dexter within the university hospital setting, and actually once applying it to that data set, we're able to identify a proportion of patients who met certain inclusion criteria, identify some controls, and we're able to outpace, so I just want to focus on that it only took us 3 minutes to do this, we're able to give you an answer of whether that patient in front of you may benefit from a treatment or not using some of the data that's held within that system. But again, we want to make this more interesting and overly complex, because that's what we love to do in academia sometimes, even though we feel like we've got some of the simple things right, and some of you are saying we should repeat them and get them absolutely right. Let's go into more exciting, complex things in some ways. And actually, can we make use of these technologies to support patients with things like multimorbidity? So you might have a patient here called Mary, for example. What do we do for patients who are multimorbid, who may present to their clinician, who may present to sort of a population-based health service, and we're really not sure what the right treatment methodology is for them because there's no trial that works or no trial that's necessarily applicable to them. Can we use our routinely collected data in the moment to provide information at hand for the clinician? So this is just an opportunity, again, to really use these tools to develop it. And then the final thing as well, just before I hand over to Adi, we're actually looking at seeing if we, right from I mentioned that concept of a learning health system, rather than just taking the knowledge from data, can we also improve sort of that use that knowledge and transfer it into practice, and then use that practice and also improve our data. So we're working at the moment with 2 big acute hospital trusts, an acute hospital trust and a maternity trust within the region, and we're applying the tool sort of within those settings to support with various elements of quality improvement. But anyway, that's enough about some of the applications that we can use, and I'm going to hand over to Adi to talk about how it works.
Hello, everyone. I'll just quickly go through the technical specification of Dexter that Jyot has seen so far. So what my colleague Krishna has done as part of his PhD process is to map all the epidemiology study into a common conceptual model, which is taking all of these cohort study, case study design, work out the workflow as what researchers do in these studies. And from a software engineering perspective, what it means is this monolith of a diagram, which is basically taking these primary care, secondary care data sources, research data sources like CPRD data, Badgenet for maternity care, and taking user inputs, which basically is specific to your study design that you're trying to do, map it through a transformation process, which is basically defining eligibility criteria for patients that are part of your study. Then define your controls. If matching is being asked by the users, we do that, which is 1:1 matching at this stage. And all of these process is basically documented in a JSON object. So every part of the process is reproducible. So you can see and understand why a patient was excluded in your study or included. We then produce what you call an analyzable data set, which is ready for your ingestion for any kind of machine learning model or any kind of regression model that you keep. Now, what we thought, if we already have an analyzable data set, we can pretty much start doing some form of analytics or automated analytics. And we started off with generating some standard flow diagrams, generating baseline table. These are standard tables and results that are produced as part of your research papers. And then we added propensity score matching on top of 1:1 matching or 1:n matching if you want to go even further detail. And we can do some instance prevalence study, which Sam is going to talk to you about of that capability and scale that we do this. So after all this process, what Dexter really produces is this analyzable data set, extraction report, which is, again, I said, tells you detail about the inclusion-exclusion criteria and what phenotypes were used for the extraction. All of these are reproducible, readable, and again, the statistics and analysis, we produce dashboards for it. Going over through a detailed system overview. So as a user, you are exposed to a web API that we provide where you can design your epidemiology studies. You can build your phenotypes in this, which we call as code builder. And we also give you dashboards of these aggregated results. And what under the hood happens is we have this extract and analyze system sitting on top of a TRE within an organization, which is next to the data that the organization is holding on. So it sits right next to it. None of the data gets out of your organization. We take our software, put it in your system, rather than we take your data and then do whatever we want. We don't subscribe to that kind of model. Going into detail, what the database, Dexter database is basically taking your electronic health record data, we do some pre-processing, and we transform it into a common data model that Dexter understands. And this, again, sits within your TRE or secure data environment. Then we have two sets of web application, which is the Dexter web application where you design your studies, epidemiology study, and then the code builder where you build your phenotypes, describe that. And all of this, again, needs to be secure, so any kind of sensitive information we keep in something which we call as HCP vault. All your sensitive passwords or any kind of links are kept in this, independent of the application within. This is standard protocol that is practiced in industry standards to make sure that our applications are secure. The next bit is the epidemiology engine, which is based on the Java technology. It uses Spring Boot for the web application. And the analysis engine is completely written with Python. So all of this, what happens is a backend job where you submit the study that you need to do. We then analyze, produce the data, which is again pushed into the TRE, and if a user has access to, they can then do whatever they want with this data set. And the analysis engine again picks up this analysis-ready data. We churn up some analysis and then push a static web application or data through a dashboard that we are creating. So with that, I'm going to switch over to Sam. He'll talk more about in terms of the scale and application of these analysis that we do through Dexter.
Right, so what we wanted to, we wanted to sort of have a look at how we might go about looking at inequalities across conditions, and Jot, he found an absolute massive list of conditions, so that gave us a nice, big, firm example to go from. This list of conditions had 281 conditions on it, give or take maybe 5 or 10, so I think after all the processing we had about 276. But basically what we did from the beginning is we defined what exactly we were looking at, we defined the study period. Sorry, that's incorrect. So 2001 to 2021, population patients in practices using vision, age 0 to 115, so we're using CPRD data. Eligibility, sufficient data quality, there's a load of standards on Dexter which go into determining this. And the outcome, diagnostic codes for, as we had at the end, 276 phenotypes. And one of the big things that we wanted to do with the analysis side of things after Dexter outputs the analyzable data set is reproducibility. So this is just a slide looking at, so we first of all wanted to look at instance rate and prevalence calculations. Now, the boss, he said, let's start off with this, nice and easy, numerator over denominator, let's try this out. And I think we had a handful of data scientists all run the same data set, and we all came out with slightly different values for instance and prevalence. And we realized that actually defining how we're going to calculate this, who classes as being in a denominator for a certain period of time, and a numerator, it became actually quite tricky. So we set out to define a clear set of, what's the word, just things that patients have to go by in order to actually be defined within these periods. Now, this is clearly stated on Dexter, so it's very reproducible, and it's very easy to understand and interpret. So after we calculate our incidence and prevalence, we then wanted to do some direct standardization. This is just to make some of the results more easier to interpret. And yeah, we followed NHS Digital's way of standardizing. And again, everything was very clearly followed from a document specifying the statistical pathways and things that are done. So again, it's that reproducible, yeah. So after this, we then had an absolute ton of data, 281 conditions, 276 even, all our age, sex, standardized results, and we had to try and figure out what we wanted to find from these. So what Neil did, as he was mentioned earlier, is he came up with the idea of a Z-scoring approach, where what we do is we model risk ratios on a Poisson distribution, chi-squared. We do a chi-squared test on the Poisson distribution to come up with Z-scoring for each of the conditions for each subgroup. And I will show you the outputs from that. Yeah, so just quickly showing this while it came up. So it's basically what we're doing is we're sort of, for each of the subgroups, so let's say we're looking at ethnicity here, we have the prevalence ratios on the bottom of the graph, and we're trying to look at which ones come outside of that funnel that we've got in the middle. They're defined with the Z-score, and then the idea is we could then look at those, and it sort of helps define an area of interest from this massive breadth of information. So what we got in the end, simple incidence and prevalence outputs. Most of these were mainly from sort of things that you could see from the white ethnic group, which obviously is going to be the most wide population in this data set, which is why it's important by categorizing them by ethnicity and looking at them in this way. So we've got the prevalence ratios. These were defined, so this sort of mean that we found, they're all relative to the general population, the whole population in the data set, which is why you can see the trend in the white population is very, very central. But yeah, this came up with some findings such as HIV being very, very high on that Z-score and on the risk ratio as well. But this is just an example of an output that can be brought out from this, and we've chatted with people in our department, especially about the HIV side of things, because we did think that was, that was quite, I mean, it's just where it says thalassemia trait there, the labels are overlapping, but, we checked this with her, and she said it's actually relatively normal. So, as I said, this can bring up, flag certain conditions here, and just make it slightly easier to look at. It's also worth mentioning as well, when defining ethnicity in our data set, I mean, it's an absolute minefield. When we first used the straight categorizations from CPRD Gold, from Vision, we ended up with a massive, quite a trend of the black ethnic group with gastric conditions, which then went away when we defined an other way of defining the ethnicities. This is, again, it's something you can do downstream in the analysis. This could potentially be something significant, and it's something that we've planned to continue looking at later on down the line, but these are all things that have just been flagged along the analysis pipeline which this has provided. Also, all of this graphing here, all of the methods and things, they're all outlined in Dexter, and it's a library that we're planning on getting out in Python as well. So we'll have the Dexter software, and we'll also have a Python library which will allow you to do all the analysis on, which we're developing for the moment. On top of this, we've also got an intersectional method that we're currently working on. This is very much in its draft phases. The idea of this is that we're trying to figure out, rather than looking at each sort of factor as an individual, we sort of look at all the factors that sort of make up a person. So here I think we're looking at ethnicity, age category, and sex as an example. It's not standardized, it's just looking at all three groups. And what we've defined here is the incidence and prevalence for each age, sex, and incidence and age, sex, and ethnicity combination. And the idea is, obviously, the more of an intersection you take, you get a lot more groups, and within each of those groups you'll have a lot less patients, so less statistical power, and it's a lot harder to analyze. And the idea is here is we wanted some sort of clustering approach that could potentially identify a group of patients that show similar patterns in the outputs that you've got, which you could then potentially look at downstream, pooled together, which will then give you more patients to look at and more power to your tests. So this is just one example of one that we found currently. Where, again, it's in its draft phases, but we just picked out the 9th cluster within this Bayesian hierarchical clustering of the data that I've shown you. And this data came up with a majority of others are mixed, black and missing, which, again, we haven't looked at how significant this might be downstream, but it's just one that we picked out, and that made sense to us from what we understand about how, sort of the black ethnic group and mixed tend to be categorized and things like that. So I said there is a lot of exploration in these methods, and there are definitely answers that we're coming up with, and we're writing our paper on 281 conditions for the moment, but there is so much scope for exploration and actually trying to find what you want to look at with this information. And with the ease of Dexter to get that initial data set, it's very efficient in the grand scheme of things. I mean, all of these 281 conditions here, it did not take long to run all of this. I mean, it took a bit longer to make all the libraries and things, but once these are all done and easy to use, then it'll be easy to generate all of this information.
We have 4 minutes for questions. Does anyone want to put their hand up and ask a question of these people? If you would.
Hi, I'm Prashant. Congratulations. It's excellent and it's going to solve some really good big problems for NHS. My question is, if I'm inputting EMIS data into this or primary care data into this, can I input free text fields? So that's the first part of the question. The second, if yes, does it exclude the patient identifiables or something like next of kin details and things like that?
Okay, yep, so I can answer this two questions. So one thing which we didn't clarify throughout the whole presentation is this tool is effectively data agnostic. So at the moment, the way that we've built the common data model, we are able to accept different forms of health records, but also we can accept non-health care records. So one of the things that we're trying to input is policing data and other forms of anonymized data. With regards to that second specific question, yes, the schema is actually originally based on EMIS and Vision to begin with, so we can accept it. The only challenge that we have at the moment is our team has recently undergone a merger, so we hadn't started with the intention of using the unstructured data, but we have merged with a team which does utilize like natural language processing techniques to bring that unstructured data into a structured format, and then we can input it into the system. We're not currently doing it for EMIS at the moment. The only thing that we're trialing it on is with the Vision data set that was provided by one of the data providers. So that's going to be a something for us to look for in the future, and we're underway with that approach at the moment, but it's not something that we can release at the minute.